I know Obi has been out of town, so should we just not launch into it?
He's online. I think he had spoken to Mwangala to do the welcome.
Okay.
Yes, I see Mwangala is online. Mwangala?
Good evening, colleagues. First and hope that I'm audible. Can
Yes,
I please get confirmation?
You are audible.
Thank you very much. Good evening, colleagues. My name is Obakeng Moatshe. I must apologize. I may have a slight drop in connectivity. So if you'll please accept my apologies if we do have any loss in connection from my end. Once again, my name is Obakeng Moatshe. I serve as the acting MD for Intellectus Campus group of entities. We are a skills development and training institution which extends our expertise across health and social sciences. We have 8 campuses across 5 countries, namely South Africa, Botswana, Namibia, Swatini, and Zimbabwe. We'll soon extend our footprint across Zimbabwe. We are your hosts for this evening. We extend gratitude for making the time. A couple of housekeeping issues before we resume. The session today is an interactive session. It's not one which is a lecture-based monologue. So the request out of all of our colleagues who joined the session today is to be as interactive and active as possible. Please utilize the chat function to raise questions and comments. The Intellect team will work to read out those questions. You're also welcome to please raise your hand during the session where you'll be recognized to make a submission. In the chat, you'll find a link to an attendance register. Please do not put in your details on the chat, but rather through the link functionality. From there, we will be able to capture your details that will enable us to circulate your certificate upon completion of this session. This is a CPD session, CPD accredited session, so we would like to be able to circulate the certificate as best as possible. Allow me to introduce our panel for today. The topic of today is point of care testing and the breathless patient. The panel discussion is being moderated by Dr. Jacqueline Stone. For ease of reference, Dr. Jackie. Together with Dr. Jackie, who will be the lead moderator for this session, is
Oh, I think we've lost it.
Apologies for that. Dr. Jackie, may I please request that you introduce the balance of our panel? I think to be dropping that.
Okay, Obi, you're dropping out of it, so do you mind if I take over? So, evening, everybody. My name's Dr. Jackie Stone. I'd like to welcome everybody to this evening, and like Obi said, I'd like it to be an interactive session. Anari de Wet is with us. She has taught me a lot about how to use this particular device, which, if you have a look at it, is slightly smaller than my cell phone. So, Anari, if I say anything that's incorrect, please feel free to interrupt me, because you've obviously had a lot more experience with ultrasound than I have. You're kind of my trainer. So without further ado, let's progress to point of care testing in the breathless patient. Now, point of care testing with ultrasound is designed to give a rapid diagnosis. It is not designed to replace ultrasound. We are not ultrasonographers. Most of us are point of care practitioners, whether we be nurses, doctors, anybody who sees the patient for the first time, and particularly probably paramedics, where this device would be in fantastic hands. The patient I'm going to present, we're looking at the inferior vena cava, looking for hypovolemia in terms of why someone would have a low pulse and blood pressure. We're going to look at the lungs, and we're going to look at the heart, and how one device can add to the clinical picture. Now, we're looking for diagnostic pattern recognition, and as I've said, it doesn't replace ultrasound. It's part of your clinical diagnosis. You take your history, you do your examination, you may do other point of care tests, you may do a troponin T, you may do a D-dimer, you may do a CRP or a hemoglobin. But in a sick, short of breath patient, if you don't have rapid access to imaging, you need to actually be resuscitating and managing them based on what their diagnosis is. So I'm going to present this patient. I still remain in contact with, because when he walked into my office 3 weeks after this event, I didn't recognize him at all, because when I'd last seen him, he'd been so sick. But he was a 63-year-old male. He was a semi-retired IT consultant in software development, and he was diabetic and hypertensive. I won't go through his meds, but before he came to us, he had been put on azithromycin. He'd been admitted with hypoglycemia and unstable sugars about 14 days before, and he is a COVID patient. And as we know, there are lots of SARS receptors on the pancreas, and quite often the first presentation is that the glucose goes either up or down. But he was hospitalized and became immobile. So obviously into the differential then starts coming the potential for DVT and PE. About 3 days before he came to us, he started to feel tight in the chest. He started to feel a bit short of breath. He couldn't describe the tightness in his chest, but he was kind of holding his chest. And when he arrived with a positive COVID test, which means he had to leave the hospital he was in, he didn't have a chest x-ray with him, and he had saturations of 78%. He was tachycardic, his blood pressure was low, he was in mild respiratory distress, he was confused, he had a tremor, he was very weak, and he was COVID-19 positive. So we were in a 24-hour emergency clinic. We didn't have x-rays. We did have the ability to send bloods quickly to the lab. And the differential diagnosis basically includes just about everything. Did he have a viral pneumonia? Did he have a secondary bacterial pneumonia? Had he had a PE? Was there a pleural effusion? A pneumothorax was unlikely. He had been a smoker, but he'd stopped about 5 years before. And he didn't look like an emphysema patient, but it wasn't impossible. It was possible that he'd had an MI. He was diabetic and hypertensive. It was possible that he was in congestive cardiac failure, although he didn't have pedal edema. It was possible that he was in cardiogenic shock. And it was equally, well, less likely, but not impossible, that he had a pericardial effusion. He was definitely in atrial fibrillation when we had a look at the oximeter, because you can see the pulse waveform on the oximeter, and he could have had any combination of the above. He was managed according to a normal ABCD, airway, breathing, circulation, drugs, diabetes protocol. And 3 weeks later, he was in good shape. But getting back to where POCUS could have really helped us, if we'd been able to make diagnoses quicker on him, I think he might have spent less time in hospital. So one of the point of care tests that is going to come online will be a rapid troponin T. His troponin T came back about an hour later. It was negative, but it would have been very comforting, probably for my blood pressure and my pulse rate, if I'd had a negative troponin T within 10 minutes. So acute respiratory failure is one of the most distressing conditions for both the patient and the doctor. And I'm sure a lot of us have, over the last 3 years, seen patients where we have been extremely concerned and not been able to get them admitted into a facility and had to manage them ourselves. So your patient with chest tightness and shortness of breath, what if you had one of these? So if you were to do a subcostal view, you would be able to see if there was wall abnormality, whether the patient was in failure, because you'd be able to see the heart. If you could do a lung ultrasound, you can actually distinguish between several conditions. You can't diagnose them as well and as definitively as you might on a CT chest, but if you don't have a CT chest, then what else are you going to use? And the evolution of this device, or of ultrasound, over the last 3 years, I think has reflected the fact that people have done whatever they can with whatever they have. Shock can be hypovolemic or cardiogenic, and this can be distinguished with this device as well. So Anari is going to talk about the subcostal view a little bit later, which is the easiest for you to see the heart. I'm going to talk about the lung. Now, lung scanning, I've given 2 sites here. I like the one which is the 10 signs you must know. If you are a pulmonologist or in critical care, you might prefer the blue protocol. The blue protocol was designed by David Lichtenstein, and it was actually designed in the 1980s. And it was based on the fact that respiratory distress is really a very difficult thing to manage. And particularly if you have to put a patient on oxygen and you can't get them in an ambulance, you can't move them, so you have to manage them. So going through the 10 signs. Sorry, anyone got a question? No? So the first thing is the bat sign. Now, the bat sign, when we put a probe on the chest, what I want you to have a look at is if the probe is here, that's the skin. These are ribs. So ultrasound doesn't go through bone. So you get these 2 dark shadows, and in between, you're going through skin, subcutaneous tissue, through intercostal muscle, and here you get to the pleura. And the whole objective of the bat sign is to identify the pleura. And I'll show you at the end of this an algorithm. Once you see the pleura and you see the movement of the visceral and the parietal pleura moving against each other, you have your major landmark in lung ultrasound. The next thing I'd like to show you is the seashore sign. And I'm just going to see if this will actually link. Because it's good to see it in motion. And I'm just going to try and open this link, which is not going to happen, I don't think. Yes, it is. It's a very brief video. But what you can see there is this almost looks like waves on a beach. Okay, I need to go back to the presentation. Can you just confirm, Belle, that you can, I'm back on my presentation?
Yes, I can see your presentation, Jackie.
Okay.
I can see it.
So what you can see here, there's your pleura. This is supposed to be the horizon and the waves, and this is supposed to be the beat. And when you're looking at the lung, you can see it moving backwards and forwards. I don't know if you could see the shimmering. And when this is a completely normal sign, and what you will also see is the pleura will be sliding across, it'll be moving continually, and that is normal. The other thing that's normal are these things called A lines, which basically are just simply refractions of the sound wave. And you can see the rib shadows and the A lines. Those, I've never seen A lines like that. Those are very prominent ones. This is probably more, if I've been playing with the probe, what I'll see the pleural line, and then you see the rib shadow, and you see these A lines here. Now, if you see what looks like a flashlight coming off the pleura, you see these are called B lines. And when they eliminate the A lines, this is a sign of pulmonary edema or of interstitial fluid. So when you see this, you don't have to know how much pulmonary edema there is. All you've got to recognize is that the picture on the left is normal with horizontal lines, and the picture on the right suggests that this patient has got pulmonary edema and is probably in cardiac failure. So again, horizontal is A lines, vertical is B lines, and if there are more than 2 to 3 B lines within the space of 2 rib shadows, you're looking at a patient that has probably got pulmonary edema. Now, you might want to confirm that with your stethoscope, have a listen and see if there are crackles, work out if they've got a big liver and if they've got pedal edema. But it gives you confirmation of what you're dealing with. The next thing is, does the patient have a pleural effusion? Now, sorry, can we mute?
Hi, guys.
Hi, Ingrid, can you mute yourself? So if a patient's got a pleural effusion, they talk about the quad sign. Putting this device into M mode is something I still need to learn from Anari, but if we put it using just the curvilinear probe, what you will see is, instead of what we saw previously, which was the A lines, the pleura and the A lines, what I'd be expecting to see here is the pleura and A lines. What I am seeing is a dark area, which suggests the visceral and the parietal pleura have separated. So normal, as we said, you see the pleural line and then the A lines. Abnormal, there's no A lines and you've got dark fluid here, and these are the ribs. And this is what's considered as the quad sign, and it's a very definite sign that the patient has a pleural effusion. Now, had this patient had a pleural effusion, we might have been more suspicious of a bacterial pneumonia or a pulmonary embolism. As it was, when we eventually did get an X-ray on him, he did not have a pleural effusion. So getting to the shred and tissue signs. Now, I'm going to actually go to the next slide first, because what you can see is, if you look at what you expect of normal, you've got this sort of seashore homogeneous tissue. When you see these white flashes, you're seeing air bronchograms. And when it's called the tissue sign because it looks like tissue, it doesn't look like lung. And if you see an area of consolidation next to an area of normal lung, you will see these irregular white lines, and they will be moving when you're looking at it under ultrasound. So that is called the shred sign. It's a sign of consolidation. It's the edge of where consolidation meets the normal lung. Another example of the shred sign, you've got white irregular tissue that doesn't look like a pleural line on the border between consolidation and normal lung. So lung sliding will hopefully be shown now. And when you are looking between the two ribs, you will see this movement of the visceral and the parietal pleura. It looks like just one line. The important thing is, and this is one of the real diagnostic, this for me in a patient who had emphysema, who presented with shortness of breath, and I was worried about a pneumothorax. When you have a look at what happens when there is pneumonia or when there is a pneumothorax, the lung stops sliding. But if you get a transition point, it's called a lung point. That is pathognomonic of a pneumothorax. And pneumothoraces can be quite hard to diagnose if they are not barn door, stab chest, and the trachea is deviating across to the other side. But they're important to treat because they cause significant respiratory distress in some of these patients. And the thing about a lung point is you will very often see normal lung moving and then completely still lung with what is effectively respiratory distress syndrome or consolidation underneath it. And this is an incredibly useful sign in a distressed patient because you will basically have diagnosed a pneumothorax in this patient. So if you're a pulmonologist, you actually, the first thing you look for is lung sliding. If it is present, you look for the flashlights that I showed you, and you've got a patient that's got pulmonary edema. If the lung is sliding and the lung looks completely normal, you need to think about a pulmonary embolism. I don't think at our level, at primary care level, we need to get into this, but the pulmonologists do get into it, and I'm not going to go any deeper into that profile. If the lung is sliding and you're seeing the shred sign or tissue signs or white flashes, your patient's got pneumonia. If it's not sliding and you're seeing these B lines, your patient's got pneumonia. And if it is not sliding and you see a lung point, your patient's got a pneumothorax. Now, this all seems terribly complicated. But the first time we saw a chest x-ray, I show a patient a chest x-ray and they say, what's that big white thing in the middle? And it's clearly the heart. And we know which part is the aorta, which is the atrium, which is the left ventricle, which is the right ventricle, because we grew up through med school on chest x-rays. But if you don't have the luxury of a chest x-ray, this is actually a very simple way of assessing the chest. You don't have to, you have to literally know what normal looks like, and you need to be able to assess whether the lung is sliding, whether there are A lines, B lines, or whether you've got consolidation. And if you're worried about a pneumothorax, you can scan and look for a non-sliding part of lung that's adjacent to a sliding part that looks like it's got a break point. Now, I'm going to briefly go through some images, and I'm going to hand over to Anari because she is a cardiac, far more of a cardiac expert than I will ever be. But we don't have to be cardiologists here. We're not doing formal echocardiograms. When you do a subcostal view, you will be looking at the heart from the bottom. So if you look at the picture on the right, the probe is obviously sitting opposite the ventricles. So a normal view, you will have, if this heart was beating, you should see a heart beating well and strongly at about 80 a minute. In the patient I was describing, we would have seen a heart beating irregularly. It would have not had much volume in it because the patient had a blood sugar of 26 and was very dehydrated. So he was actually in hypovolemic. It was more hypovolemic shock than cardiogenic shock. And we would have known that it was safe to slow his heart rate down and to give him a lot of fluid, which he needed at the time. We also needed to bring his glucose down so that he stopped passing all of his fluid out through his kidneys with his glucose. When we're looking for pulmonary embolism, the left ventricle is usually, and we know this, is much bigger and stronger than the right. If the right ventricle is larger than the left ventricle, then that is suggestive of a PE. This patient, if this patient presented with pedal edema, a big liver, and we got the scan, the left ventricle is huge and dilated. This patient is in congestive cardiac failure with left ventricular failure. And this patient, it's not hard to see, has a tamponade. And you don't have to be able to measure left ventricular filling pressures and be able to identify the valves. You just have to be able to identify the chambers and be able to know that fluid is black and tissue is white, and to be able to pattern recognize. So obviously the big advantage of point of care ultrasound is that it's very good for soft tissue visualization. There's no radiation. The cost is significantly lower, particularly per scan. It's totally portable. It requires no infrastructure. You can do the scan in Hwange Colliery Hospital. You can do it in your GP surgery, and you can do it on a home visit. It's real time. It's not a still image. It's bad for bone, although I have seen pictures where a fracture's seen reasonably well, and it's not that reliable for imaging the deep structures. And at that point, I'm going to stop sharing, and I'm going to hand over to Anari unless there are any questions.
Okay. Let me share my screen whilst we see if there are any questions. Can you see my intro page, Jackie?
I can see it.
Great. So good evening, everyone. I am very excited to be on this short, but hopefully very impactful little webinar to discuss cardiopulmonary imaging and how point of care, whether it's ultrasound or the point of care tests Dr. Stone was talking about, can aid you in your decision making and patient management. Quick background about myself. I used to be a clinical technologist, studied pediatric as well as adult cardiology, and did extensive echocardiograms and really loved the dynamic diagnostic aspects that this imaging tool brought to us. I've since then moved into the more commercial side of things, where I was running various parts of the ultrasound business, sales teams, distributors for some of the largest ultrasound manufacturing companies in the world, mostly focused Africa. Cape to Cairo is where my passion lies and where I like to see how these tools can make a difference in our healthcare solutions. So I just wanted to refresh. I think a lot of people have seen this quote, how difficult it was to adopt the stethoscope because it's not this hue and character that we are used to, and that it's quite foreign, and it will take more time to use a stethoscope than what we're used to. And let's say we've certainly come a very long way since we were debating the use of the stethoscope. So the formal point of care ultrasound best quote I could find was definitely the acquisition, interpretation, and immediate clinical integration of ultrasonographic imaging performed by a treating clinician at the patient's bedside rather than by a radiologist or cardiologist. So many will look at this definition and then think, but is POCUS nowadays, if in the hands of anybody, does it mean we are nothing but non-expert cowboys wielding probes. I don't think that's really accurate. We are definitely not that. So I think we should define POCUS based on what it actually describes. It's point of care ultrasound. It's performed by the patient's bedside for whatever the relevant purpose is, either diagnostic or even procedural. We have seen ultrasound at the side of a sports field, which is a different, I would almost like to say, first world problem, to see if that patient has a torn or merely stretched ligament. Will a steroid shot be okay and send that athlete back onto the field, or will it be a surgical intervention later? But definitely point of care ultrasound is also in rural villages where it's life-saving scans that will inform this mother whether she is able to deliver safely, or that she has maybe placenta previa and will need to travel to a next level of care to be able to deliver safely. So huge impact on maternal and infant mortality and health, right? So when we ponder these point of care ultrasound scenarios of where it can go, does it really matter that the person performing the scan, how trained they are? And I wanted to share a couple of interesting papers that I've come across, and I'll be happy to share it with you as well. But evidence suggested that focused echo had remarkably similar clinical impact to advanced level scanning with no major diagnosis missed. I've seen similar studies in limited obstetric screening where a trained midwife could find close to 80% concordance of determining gross fetal abnormalities that a qualified obstetrician would find. The evidence is also there that using point of care ultrasound over landmark determination for arterial line insertions, that there's a 75% first pass success rate versus 0 for arterial line insertions. So in the hands of somebody who knows how to use it, it's definitely a very, very valuable tool. And this is all about training. If you practice ultrasound guided techniques, you'll be good at it. And if you practice a lot of landmark techniques, you'll be good at that too. It doesn't necessarily mean switching between one or the other will make you better. It's just focusing on what you know. And I like to use my favorite Bruce Lee quote that says, "I fear not the man who has practiced 10,000 kicks once, but I fear the man who has practiced one kick 10,000 times." And that's what we learn with POCUS, is you have a focused, targeted approach on what you want to determine, and you practice that a few times, and you'll be very quickly, with a very steep learning curve, become very, very adept with it. So just like Dr. Stone stressed as well, it's not to say that there is no role for advanced scanning. Focused imaging does have its pitfalls, and it's certainly, any point of care ultrasound is definitely not taking the place of any complete diagnostic scan, whether it's a complete echocardiography analysis or fetal anatomy scan. That's definitely still there to stay. So this is the information we can find on a high-end ultrasound cardiac scan, whether it's regional volume changes over time. Let's see if I have a pointer here. Regional volume changes will give you, instead of just a two-dimensional view, you can actually have a three-dimensional volume change over time and how the different segments change. It's of high importance when you're doing cardiac resynchronization therapies. You can map the topography of a mitral valve in 3D over time to see exactly where the coaptation is lacking, to which degree, where does it prolapse. Is this a case for a mitral valve repair versus replacement, which is huge implications for patients as well, this types of decision making. So not diminishing the very, very important role of high-end ultrasound quantifications that it can do. So what we have with UImage is a singular probe that has a linear probe on one side and a cardiac scan head on the, not cardiac, curved scan head on the other side. And with these two probes, we cover by far the majority of all your POCUS needs. The linear probe will give you superficial, high-resolution images with very little penetration, so good for vascular, musculoskeletal, carotid, thyroid, all these types of really superficial imaging. And then the curved probe will give you more of a deeper penetration, wider field of view. That's great for abdomen, obstetrics, pelvis. But while you're at it, definitely also a bit of cardiac. And that is what we want to have a look at this evening quite quickly. So because we have a number of views in the cardiology scans, and this is something I hope we all get a chance to do a bit more hands-on and face-to-face or with a patient. It's difficult to do that online, but I wanted to give you a flavor of it, and then we can decide how much more detail you would like on it. But there's 4 basic views, right? You have the parasternal long axis, and then the orientation of your probe is very important. So this will be to the patient's right shoulder, if I can put it like that, and you will find this long axis view. There's an ultrasound image and then a diagram of what it would look like. Rotating the probe 60 to 90 degrees will basically just cut that longer shape in a short axis, and that is when you will get the parasternal short axis. And this is on the papillary muscle level of the left ventricle. Then you have the apical forechamber, which is right, by the way, this is just left of the sternum, right, between the 4th and 5th intercostal space. Apical forechamber is right there on the apex that you will hopefully even be able to feel. Place your probe there. And then the other one is the subcostal view, which is just beneath the xiphoid process. Sometimes, mostly in pediatrics, we will also do a suprasternal view to look at the aortic arch, and that's more, I think, for congenital purposes. But yeah, I think these are the basic views that will allow you to do a focused, assessed transthoracic echo. With the curved probe, it's because your field of view is a little bit larger, it could be a little bit more challenging, but definitely I thought we would focus only on the subcostal view because the curved probe is definitely very well suited for that one. So I'm going to go through these quickly just to show you all the information you can get from a long axis, and then that is purely probe manipulation that will give you more information. If you're on a long axis view, you will get your typical long axis, left atrium through the mitral valve, LV, aorta, and some of the right ventricle. Now, by simply tilting the probe tail end down, in other words, you are tilting upwards and getting a more of an anterior view, you will then be able to see from the exact same spot, you can get the right ventricular tricuspid valve, right atrium view. And then the very same, just exactly the opposite sweep, if I can call it that, just by tilting the tail end of the probe up and down as you're scanning, you will get the right ventricular outflow view, which is closing off the LV, and then the RV flows into the pulmonary valve, into the pulmonary artery. Rotating the probe 90 degrees, you get your short axis, and this will really, this is the aortic level, and now it's just a matter of scanning up and down the short axis. Aortic level, which shows us the very famous upside down Mercedes-Benz sign, to the right ventricular outflow tract, going a bit down to papillary muscle level, also the well-known fish mouth. In pediatrics, you go just a smidge more down in that, and you will get what we call the Mickey Mouse sign, because you would see the 2 ears and the head of Mickey Mouse. And you can sweep this all the way down or right into the apex and back up. Now moving from the parasternal view to the apical view, you would get the apical forechamber. This is the easiest one that we all know and recognize. Forechamber view. Slight rotation, you can get the 90-degree cut, if I can call it that, of the left side of the heart. We call it the two-chamber view for LV, mitral valve, and left atrium. And then a slight tilt, again anterior, and the outflow tract should make itself visible for the left side, which is the aortic root. And that is the apical views. But let me just spend a couple more minutes on the subcostal view. Jackie, are we still okay on time? I have just a handful of slides left.
No, I think the subcostal view is the most important one.
All right. Okay, wonderful. So I wanted to just refresh you on the probes. Linear probe, superficial, higher resolution, not a lot of penetration. The phased array probe, also known as cardiac probe or sector probe, which is ideally for your cardiac imaging because you want to get into the intercostal spaces. But then the curved array probe, which is I would call our gateway probe into cardiac imaging if you are already using point of care ultrasound and you are doing some fast scans of abdomens, etc. So subcostal four-chamber view is the easiest one to scan. It's one of the most important views of bedside cardiac echo because you use this view to evaluate pericardial effusions, including tamponade. It's also quite good at encoding scenarios if you are working in an ER or critical care in the hospital. And it's handy because cardiac compressions doesn't interfere with the person doing the compressions if you're actually scanning. And then in terms of anatomical landmarks, it's just below the xiphoid process. It can be sensitive for the patient sometimes. So as we hold the probe normally like this, let's see if my big Sharpie will, like this, an underhand approach. I like to do an overhand approach for subcostal, just because then your knuckles are not also digging into the patient's abdomen and be a little bit more comfortable. And you really need to get quite deep in there. You want to elevate that your probe is almost leveled with your patient to get right into that anterior view to see all the structures that you wanted to see. The markers of the probes are always important, and from a subcostal view, it's usually around the 3 o'clock position. And like I said, just try to get as low in there as you can to almost parallel to the patient's abdomen. Another nice tip is if you have a cooperative patient is to ask the patient to take a deep breath in. It tends to push the heart a little bit. If they can hold their breath for a few seconds, you could get a couple of beats of really good imaging. Then as they breathe normally, it will, the image can come and go. But yeah, breathing in and out for the patient usually gives you a good view as well. So from subcostal, the four-chamber view, which I've just shown to you now, you will always see a bit of liver and a nice big pericardium, which you can also see helps you to identify effusion versus cardiac effusion versus pleural effusion. You can also get the long axis subcostally, and it's a very, very good way to look at the IVC. And that's, of course, like Dr. Stone mentioned earlier, very important to see if your patient is hypervolemic, if the IVC is distended. You can look at the hepatic veins and determine your treatment from there. Again, as we talk about the probe positions, which we will do in more hands-on or as you play and learn yourselves, rocking side to side is one way to get your images. And I've spoken about elevating by dropping the tail end of the probe up or down so you get more anterior, posterior views. And then just rotating, which is different to just a sweep, right? A rotate will now get you instead of a long axis, a subcostal short axis. So it's not exactly the same as your traditional short axis. It's a slightly different cut, but it still gives you good enough views to determine if your patient is, the LV is contracting enough, if the volume looks okay, the valve looks okay. Here, your RV will definitely give you a hint if you're looking at a pulmonary embolism for sure. So yeah, that's just some of the views you can get. So when you looked at that incompetent cowboy we saw in the beginning, falling off his little ox, I think we can definitely say that a focused cardiac subcostal start will definitely help you to get a good idea of where you are. So we mostly look subcostally. Of all there's so much you can see, and I think Jackie makes a very good point with the pattern recognition, right? Was there a question? No. So pericardial effusion, cardiac motion or standstill, right ventricular dilation for maybe heart failure, pulmonary embolism, and then ventricular contractility is the left ventricular systolic dysfunction. These types of things you can all see. And Jackie, you mentioned one thing that I thought was very good. I take M-mode for granted sometimes because M-mode was the first imaging mode really in ultrasound. Before we had 2D, M-mode came first because M-mode is a one-dimensional view. But I will certainly add that next time because M-mode shows you movement over time and a singular line. So if you have 2 points, whether it's the ventricular septum in systole and diastole becoming thicker and thinner, and you want to measure that, it draws you a beautiful waveform and makes the measurement very easy. And M-mode is standard on everything. So I will certainly add a bit of M-mode to my slide deck here. One more thing I wanted to ask or say about the subcostal view is a little mnemonic that I always use when you start scanning. There's 3 things you got to remember. Set your depth correctly. You don't want a little ultrasound picture here in your scanning sector and you're wasting all this ultrasound space or ultrasound potential information on just noise. Orientation, make sure you have it correct, that is to the patient's right or to the patient's head. That way it will be the universal standard of when you're scanning. It's as if you are interrogating your patient physically. What you see on the screen, what is left is right, and then from apical, what is up is down. But other than that, it's pretty straightforward. And don't be shy of gel. If all else fails, use more gel. If you have a big black dropout, it's a rib that's in the way, and no amount of gel will rectify that. So I wanted to show you a little bit of ascites, pericardial effusion. As a matter of fact, I would even debate that this is maybe even a bit of a tamponade, the way this wall collapses. And the most interesting scans of these kind of subcostal views I find on nephro POCUS. The nephro community is really seeing very amazing and interesting scans. Jackie, do you want to hazard a guess on what we're seeing over here? I call it a close call. So there's definitely yeah.
Is that a atrial embolism?
That's correct. Yes, there's definitely a thrombus there, highly mobile.
Atrial thrombus, sorry.
Yeah. So it's like by the, I don't know, it's touching against that valve. I mean, if it goes into that ventricle, it'll be a catastrophic event for the patient. So this is a very angst-filled image for me to see. But yeah, that's beautifully captured on ultrasound though, seeing that hypermobile body moving around there. This is also an embolism, and I just know that from the history, but you can definitely see the right atrium is hugely distended, and I know the right ventricle must also be, the IVC is just massively distended. So there was a massive pulmonary embolism event on this patient. Oh, I just had that image again. It's obviously been something to see. So yeah, that's in a nutshell what we have. I wanted to just show you some little bit extreme cases, but give you the confidence that if you're already scanning and you're doing abdomen, which is usually where everybody starts, and you can have a bit of a look around. It's really a quick, easy way to do a good subcostal view. And before you know it, I'm pretty sure you'll be doing a good FATE protocol, or at least some basic long axis, short axis for chamber and subcostal. You've got those 4 views down, and your point of care cardiac ultrasound can become a very integral part of your interrogation of your patient's symptoms. And with that, I'm going to stop sharing and we can maybe take some questions. Jackie, I'll hand it over to you.
Thanks very much, Anari. I'm going to let Tina come on. I know she's prepared something. Tina, do you want to start sharing your screen?
Sure. Good evening. Thank you, Dr. Stone. Let me just share my screen quickly. Okay. All right. Can everybody hear me?
Loud and clear.
All right. Okay. So my name is Tina. I am a medical devices rep with DMD Healthcare. Oh, sorry. What happened there? Okay. I'm a medical rep with DMD. And we are a part of the Avacare Health Group, which is a multinational company that operates in over 20 countries globally. Our objective as a company is to provide integrated, innovative, and holistic healthcare solutions.
You're sharing, Tina. Are you sharing?
You're not seeing it. I am sharing.
No, we're not seeing it.
Not sharing it. Just again.
All right, let's just try that again.
You're supposed to be the techno genius, Tina.
I am. I am, Dr. Stone. You know this.
Even I could screen share.
There we go. Can you see it now?
Yeah, we can see it.
Okay. All right. Sorry, I'm using somebody else's computer, so it happens to the best of us. So as I was saying, the Avacare Health Group is a multinational company that operates in over 20 countries globally. And our objective is to provide integrated, innovative, and holistic healthcare solutions to all. Our history and our pedigree speaks to who we are at the very core. So when I speak about our history and our pedigree, what I'm talking about is we have over 9,000 products on offer and over 28 years of experience in this business. And we have over 1,500 successful, highly skilled personnel in our company. And our main aim is to supply the continent with products that are affordable and of high quality. And so just a brief description of what I think happened with the POCUS is from laptops to tablets to telephones, there's been an increasing interest in the miniaturization of technology over the past several decades. And ultrasound technology is no exception, which is where the POCUS comes in. Healthcare providers can now perform point-of-care ultrasound at the bedside using handheld machines of varying sizes that are considerably more portable than the traditional full platform systems. So I think from Anari's presentation, she told us where she used to work. I'm not sure if it was in this presentation, but yeah, she used to work at GE and all of that. But you can see that there's been a gradual progression in POCUS devices. And then what is POCUS? It's been mentioned, but we don't want to take it for granted that everybody knows what POCUS is. POCUS stands for point of care ultrasound, and it's not intended to replace normal ultrasound. And this refers to the use of portable ultrasound machines for medical diagnosis at the bedside. It's been widely embraced as an extension of the physical exam. And like Dr. Stone has mentioned, it is an extension of we want it to become an extension of the stethoscope. So essentially, we want to place it in the hands of every clinician. And then just as a side note, an estimated 2/3 of the world's population have no access to basic diagnostic imaging, which is again where POCUS comes in. and then enters the U image. So the U image, as Anari and Dr. Stone have mentioned already, is a 3-in-1 wireless ultrasound probe, a linear, curvilinear, and a cardiac probe that produces whole body scanning capabilities in any environment. And just while we're there, this is a small, lightweight, ergonomic, compact design device. It's 90 grams in weight, and it's pretty much as small as your phone. So just in case you haven't picked up on what it is I'm talking about today, I'm just talking about the device as a device and not as a medical person, because I'm not a doctor. And this device is accompanied by a high definition tablet device, which is a Samsung device, right? It is a multi-purpose device for symptom detection and for reduced intervention time. What it was intended for is to be used across all medical disciplines that perform imaging. It promotes improved access to care, provides opportunities to improve your scanning skills through our proprietary platform. Anari again spoke about this when she said practice is what is going to make you better. And we've got resources that will allow you to improve your scanning skills, to get trained up, to get accreditation through the Intellectus Campus and through sessions like this. And the POCUS has gained widespread adoption among hundreds of African medical professionals as their preferred solution for reliable portable ultrasound imaging. So when they were developing the U image, what they were looking for was durability. Will this device stand the test of time? And what we found is that the U image is drop proof, which means you can drop it. It is waterproof, so therefore that makes it quite durable. And it helps if we're saying it's a portable device, because then you can travel with it, as Dr. Stone has mentioned, that you can take it to Wange Colliery, you can take it to all the mines, you can take it anywhere, basically in your pocket. And then they also were looking at the battery life. You can use it 4 hours continuously without the battery dying, which is a plus, because we're experiencing, as you all know, in Africa, we're experiencing load shedding. And then ease of use. It's very easy to learn how to use this device. All the people we've placed this device with have managed to use it pretty much in a day. As long as you give yourself some time to play around with it, you'll be able to use it. It's accessible. It's available. The app is available on the Android platform, and it provides you with high quality images. And also you've got access to a peer network, and you can save your document, you can save your pictures and your videos onto the cloud. And the other interesting thing is it's also affordable, in that when you buy this device, you are not, there are no hidden costs. There's no subscriptions that you need to pay for any software updates that come up. And there's an initial training, obviously, that comes. So it's pretty much designed for our market. And then who can benefit from this device? So this is not a conclusive list of who can use this device, but general practitioners, ambulance services, casualty departments, anesthetists, sports medicine specialists, obs and gynaes, urologists, the ones we were talking about just now, can also use it. The benefits of POCUS are that it's accurate. It provides you with accurate information for you to make a diagnosis. It's efficient because it's quick, it's in your pocket, and you can go about your day just as soon as you've made a decision. It reduces the time taken to formulate a diagnosis, and treatment can be administered within the golden hour, which reduces mortality rates. So earlier today, Dr. Stone spoke about the golden hour. I'm sure most of you on this chat know what the golden hour is. It's the hour, it's the 60 minutes between a patient arriving in your ED and them leaving. If you're able to make a quick diagnosis and send them to theater, send them to a ward, or whichever in that hour, then you've pretty much helped them and you can reduce mortality rates quite a lot. It allows
I'm going to interrupt you there, Tina. So the golden hour, if you don't act within the golden hour, and one of the things that concerns me, because a lot of junior doctors these days need to wait for a test before they will initiate treatment. Whereas when I was training, I would have been failed if I didn't empirically treat, because it took 2-3 hours for any test to come back. So your mortality rate and your morbidity rate, so your death rate and your long-term disability rate, will go up significantly if you do not initiate the correct management within the first hour of a critically ill patient arriving in, whether it's in the ambulance or the emergency department or wherever the point of care is. So, and it seems to have been forgotten, because I ask a lot of people now about the golden hour and they don't know what I'm talking about.
Oh.
But it was hammered into me at med school, and that is, once the patient presents, wherever they present, if they're 8 hours away by ambulance, you better be getting the right treatment while they're in the ambulance. Otherwise, your chances of losing them go up significantly. So sorry to interrupt you.
Oh, no, that's all right. It's pretty much fine. So just for those, well, I'm pretty sure now you know what the golden hour is, but when I was preparing my presentation, I was preparing it for doctors who know it. So if anyone has questions about this, I'm sure Dr. Stone will be pleased to share some studies on it afterwards. But basically, you can administer treatment within the golden hour if you've got POCUS available in your practice. And then just a case study I found interesting that was done on point-of-care ultrasound in morbidity and mortality cases in emergency medicine, and who benefits the most from POCUS. And the primary objective of this case study was to determine the perceived impact of POCUS in high-risk cases that presented at emergency medicine, morbidity and mortality conferences. So what they found in this study is that in cases where POCUS was not used, it would have likely prevented mortality and morbidity in 45% of those cases. This is where they didn't use it. POCUS was felt to have the greatest potential in identifying missed diagnosis. So what we're saying here is that POCUS allows you to not miss anything. And like Anari said, it's better to get a 77%, to see 77% of something than to see 0%. So it was found to have had the potential to reduce or prevent M&M in 45% of cases. And cardiac and lung POCUS were among the most useful applications, especially in patients with cardiopulmonary complaints and in those with abnormal vital signs. So from this study, we can see that POCUS has got the potential to pretty much change your practice. And with that, I'll just leave it to some of my colleagues here from the Avacare group. If you're in countries that are not Zimbabwe, they'll direct you to where you'll be able to find this device. But if you're in Zimbabwe, we are currently distributing it at DMD Healthcare in Masasa, and these are my details. If you need this presentation, I'll be able to share it with you. So thank you. I'm just gonna stop sharing my screen now, and Dr. Jackie, you can take it away.
Okay, thank you, Tina. That was brilliantly done.
Great.
And I'll open well, let's have a look in the chat. One of the questions which Anari will have to answer is, what frequency is on the curved and linear probes?
Yes, good question. So the curved probe, and I might speak under correction for a few megahertz, but the curved probe traditionally is 5 to 1 megahertz, and then the linear will be 12 to about 5 or 6 megahertz. So nice broad frequency ranges, But obviously it's important on your curved probe to go down to that 1 megahertz, because it means it will give you a penetration on your abdomen of about 30 centimeters, which is really valuable in your patient population, especially if you tend to have larger patients and you need that penetration through the adipose tissue, right? So curved is usually 5:1, linear about 12 to 5:6, somewhere there. Not changeable frequencies on point of care. The whole philosophy is to make it very, we call it plunkable. You just plunk the probe down and scan away. So there's very little to change in terms of settings and presets and all these types of things. So you will have your depth, overall gain, you even have a bit of TGC, and that's it. You just scan away. Then you can add your imaging modalities, M-mode, color, pulsed wave, Doppler, it's all there. So you can confidently say, is this a vessel or not a vessel? Is this a nerve? Is this flowing? Is there velocity, not velocity? I hope that answers the question. 2 questions.
Thanks, Anari. The one thing that we haven't really spoken about is Doppler. And while at one of the conferences, somebody came up to us and was complaining about a mass in the neck. And it was actually the external jugular. And she was in diastolic heart failure. And it turned out that she was hypothyroid, which was just a surprising thing. It was so easy to turn on the color Doppler and to see that, look, as soon as she valsalved, there was a clear backflow. But using the actual image with her looking at it, you could see that on the Doppler perfectly that there was flow and then there was backflow in the actual vein. So something we haven't really spoken about that much is the Doppler, but I found the Doppler very useful.
Very, I think it could be a very nice topic for a follow-up chat, especially, I cannot talk enough about how beautifully dynamic ultrasound is. It's real time. You see exactly what's happening. You see the velocities, and even just physically, pushing the veins. Are they collapsing or not collapsing? All these things are on the spot information that really helps you make your decision. So yeah, Doppler, whether it's color Doppler or pulse wave Doppler, it's I think that could be a separate chapter.
Great. There's been another question that's come up that someone's just sent to me. Do we have any of these devices with a computer-guided app?
I can take that. So yes, these wireless dual probe handheld ultrasound devices like IMedrix works with an app on your Android tablet. So any Android device, and that is your screen. In the past, you had to purchase a fully fledged ultrasound machine, which has the probe, the beamformer, and your display. Nowadays, the beamformer can be inside the probe, and that's the technological breakthrough. And then you bring your own display, whatever display you like, your tablet, your phone. So it's all app-driven.
This question was actually asked at a conference, at one of the gynae conferences. And you can actually apparently, as long as you've got Bluetooth, literally link it to a smart TV. This particular doctor liked a big screen and he wanted to know if he could link it to a smart TV, and apparently you can.
You can. The IMedrix works with Wi-Fi to your primary screen, which is for your eyes, and I would caution against making it too big, because you would probably feel that you are losing a bit of resolution if it's really blown up. But if it's an obstetrician, I would bet it was a secondary monitor to slave with Bluetooth from your primary one, which is for the benefit of the patient, right? To be able to see, what the fetus is doing and what it's looking like. So I would probably guess if it's a secondary monitor, absolutely, then you can go really big and it will look very impressive.
Yeah, well, it was it was an obs and gynae conference actually. So you nailed it. Right. Any other questions?
Please talk about the Wednesday evening series and upcoming events. Was the last one I see there.
So the Wednesday evening series, we will be trying, well, we should be running a POCUS session at least once a month. And so we've got certain themes running. Integrative medicine is one theme. Substance use disorder is another theme. Ethics is a third, and POCUS is a fourth. And then we will be doing a series of 3 lectures on HIV as well. So for the moment, we should be rotating through those subjects as they seem to be the most topical at the moment.
And then there's a question Tina will take directly with the doctor on the pricing question.
Okay, so in Zimbabwe, it's currently going for $3,600 US. Yeah, we are offering payment terms for those who'd like to purchase. Please feel free to contact me directly.
And the one other thing, but I can't guarantee how soon this will happen, is that we are working on tariffs so that a doctor who does a POCUS, particularly if they've been certified in POCUS, will be able to claim back on it. One of the things that I've certainly found is that patients will never, one of the things that I've said about POCUS is it brings control back to the GP, because if the GP can exclude life-threatening illness, such as ectopic, such as ruptured spleen with blood in the abdomen, then they can manage the patient for longer without referring them. And very often with one of the complaints that a lot of primary care doctors have is once the patient has seen a specialist, then they very seldom return. The specialist will often take over their care, and then no one benefits because the medical aid generally only pays for 3 specialist consults a year. So in terms of being able to bring everything back into the GP surgery, if you have the ability to ultrasound, and if you have the ability to do point of care testing, including things like CRPs, D-dimers, troponin Ts, there's 40 pages of tests that you can do on point of care. I think that the GP will be able to manage the patient far better. In the rural areas, places like Wangi Colliery and the Charles Saunders Hospital in the Lowveld, they will need to know when to call an air ambulance, or when to transfer, or when to go straight to theatre. And for people in casualty, I think it'll make a big difference to patient outcomes. The other thing that I would say is, apart from the GPs being happier, I mean, the most important thing is the patient outcome. So the GP is more confident, the patient is more confident. We did a shoulder injection probably about 2-3 weeks ago, in which the GP actually proved that the device was drop proof. And I think we were in and out of that shoulder in about 30 seconds. I was holding the scanner and the needle went in. We missed the osteophyte. But the thing was, the screen was in front of the patient's face. And because we were standing behind the patient, and he saw the needle go in, he saw the steroid and the local go into his shoulder, and we were out. The speed at which it was done, for anybody who's doing joint injections in sports medicine and orthopedics, was such that you could probably confidently book 6 an hour if you had a good ultrasonographer, or if you had somebody holding the probe. So the speed at which it's done makes it cost effective. but there's no poking around and jabbing around, and which makes both the patient and the doctor uncomfortable. You can see exactly where you go and you guide your needle tip in, you inject, you're out. Bye. And the patient was delighted. He was, we need to also understand that patients have lost confidence in the medical system, I think, in the last 3 years globally. And to have somebody who can confidently scan, who can confidently do some tests and say, this is what's wrong with you, I think will make all the difference in the world to patients who will maybe choose a doctor instead of Google before they go to the pharmacy.
Yeah, that's true.
That is true, Dr. Stone. Absolutely.
Cool.
Thank you. We'll need to wind down now and close the meeting.
Well, thanks, everyone. Do we need to wait for anybody else to enter their details? What I think we should do is maybe just leave the registration form open for about 10 minutes and then just say to everybody, thank you for coming this evening, and have a wonderful rest of your evening. I hope wherever you are, you're warmer than I am.
Dr. Stone, can I just say, for anybody who requires training in POCUS, who needs training in POCUS immediately, please can you drop us an email or just write in the chat so we can consolidate and plan for it. And also the types of training that you actually need.